Hi everybody, my name is Dr. Ryan Howard, and I'm presenting today on the efficacy of temporary anchorage devices in skeletal open bite correction, a scoping review, which is also in collaboration with Mason Mullaney, Charles Sheffield, and Dr. Alan Pani. So to start off, we have no conflicts of interest. To give some background, so today for the presentation, focusing on anterior open bites. And so if you look at the picture in the upper right, you can kind of get an idea what an anterior open bite is if you're not familiar with orthodontics or orthodontic issues. Basically, what happens is the anterior is open, and that's characterized by a lack of vertical overlap between the upper and the lower teeth. There's different variable etiologies. Generally, though, it's due to overgrowth in the vertical of the posterior dental alveolar processes, or it can be due to parafunctional habits such as a tongue thrust or other things like that. In the past, the only way in which we could solve this is by use of fixed appliances. You can extrude those anterior teeth there, but can result in more gummy of a smile, or you would require surgery. Lately, we've seen an increase in the use of these temporary anchorage devices or mini screws in usage to be able to close these anterior open bites by intrusion of that maxillary posterior segment. And so that's what we'll be focused on today. So our objective was to summarize the currently published evidence related to that, to the efficacy of skeletal anterior open bite correction using TADS. So methods, so look through the entire body of literature. 6 databases were searched in order to locate different published articles in which we could use. There was screening performed by 2 independent reviewers. Data extraction was performed to be able to pull out all the data from all of the articles, and then information about article type, study design, participant characteristics, interventions, outcomes were extracted, summarized, and synthesized. So part of the methods here, we basically wanted to focus on studies that were high evidence studies that had a large sample size, had a good base of research, and we didn't want to focus on anything that was mainly based on opinion or anything such as that. So inclusion criteria, we like to look at human subjects where the main issue was open bite malocclusion, not due to craniofacial deformities or TMD or ankylosed teeth. We want to look at people who had open bites but it wasn't related to any other etiology. We wanted to look for, like I said earlier, randomized controlled trials, prospective clinical trials, retrospective clinical trials, cross-sectional surveys, as opposed to narrative reviews, editor's choices, those kind of things. So results, initial screening of those 6 databases resulted in 837 different articles. We removed duplicates, left us with 478, and then they were screened based upon our inclusion exclusion criteria, which were kind of what we talked about earlier. Things with fewer than 10 subjects, or they didn't include TADS or other etiologies or that kind of thing, and we were left with 36. And then as we were reading and kind of continuing, we found that there were 6 more that didn't quite meet our criteria, left us with 30 quality articles for our scoping review. So here's a pie chart here, just to kind of give you a summary of the selected studies. So we had 15 cohort studies, 1 randomly controlled trial, 8 cross-sectional studies, and 6 case control studies that were included into the study. So the most fascinating thing for me as an orthodontic resident was there's a slew, a crazy variety of different temporary anchorage device setups. Here's just 4 of them. So in the upper left here, there's mini plates which are screwed into the zygomatic buttress area, and then there are springs attached from there to the teeth. And in this setup, there are 4 different bands all kind of soldered together around the teeth that can kind of hold them as a unit as intrusion is happening. In the upper right there, we see that there's a temporary anchorage device hooked up to a posterior bite block, which can also aid in the intrusion, because as you bite down, that also on that bite block that also provides an intrusive force along with the springs attached to that TAD, so it can kind of increase the effectiveness there. Bottom left is a similar setup, and the bottom right there is hooked up directly from the TADs and then the springs attached to the TADs to the teeth. And so there were a massive variety of different ways in which the researchers set up these different TADs. So here's a summary of them. A lot of them used 4 TADs. Some of them used only 1 per side, and then some of them used 2 per side. Some of them used 1 mid-palatal TAD and focused on a lingual approach. And then a lot of them needed anchorage as well to kind of hold everything and make sure that as you're intruding those upper teeth that you're not getting flaring out to the buccal. So they needed a cross arch anchorage unit like a TPA or a transpalatal arch, a Hyrax or quad helix, something like that, in conjunction to the TAD setup. So talking about our results, so first here is overbite correction per TAD type, and so in the red is the mini plates, and in the blue is the mini implants. And so mini plates were more common and kind of a precursor to what we're seeing now with these TADs. And the mini plates basically would require a surgical flap to be opened, and then they can be affixed to the zygomatic area, and then part of it will be left intraorally, in which you can hook up springs or that kind of thing to a design to provide that intrusion, whereas TADs are pretty much non-surgical, and you can just a small bit of local anesthesia and then the insertion of the mini screw and then attachment. So in the past, we've focused more on mini plates as an orthodontist, but now we're seeing more of these mini implants. So when we're talking about overbite correction per TAD type, they're pretty comparable, with mini plates being slightly higher of overbite correction, but not by a lot. Also, another measurement that the researchers used in the articles were maxillary first molar intrusion per TAD type, and here we can see that they are pretty comparable as well between the mini plates and the mini implants. The only thing that I would say is with the mini implants and bite plate portion, which is that middle blue, there are only 3 studies, and so there was kind of a big difference between the first molar intrusion amount. One said 4, one had 2, or a little over 2, and so there's not quite the body of studies that would kind of make that more centralized figure. Here, part of the results is the anterior open bite correction times per TAD. So the researchers reported a different amount of times using the appliance in comparison to the entire treatment. And so you can see there's pretty comparable amount of times between duration of usage of intrusion with the mini plates versus mini implants, with the mini implants being a little bit longer, but pretty comparable. So the researchers also seem to select mini plates a little bit more in the severe type anterior open bites, which are typically open bites of 4 millimeters or more, compared to those mini implants, which were used for more moderate and mild cases. So results: overbite correction was achieved by mandibular counterclockwise rotation. So as you intrude those maxillary molars, the bite was closed by the mandible coming up and doing a counterclockwise rotation. So in most of the studies, the mandibular arch wasn't really used. One, because the problem is the vertical overgrowth of the posterior upper segment, not the lower segment, and also the bone is way more dense in the mandible, and it's harder to intrude. Most cohorts included class 1 and class 2 subjects and very few class 3s. Results: there were not very many complications. Sometimes there would be loosening of the TADs, and so they would just replace them. And only one study reported that there was a difference in selection criteria of the implants versus the plates, and they reported that they had a preference for mini plates in cases of sagittal dentofacial deformity or class 2 or class 3s. Results: so in comparison to orthognathic surgery, we get comparable results, which is amazing, not having to go through with the orthognathic surgery, but it's way less invasive, less treatment time, and much lower risk for complications. Clear aligners, of course, are not as aesthetic as clear aligners, and so that's a that's a thing as well. So in conclusion, all cases were successful in all these different articles. No matter what the setup was, whether it was mini plates or mini implants, they were able to achieve closure of that anterior open bite, which is amazing. There's many different TAD designs that work and that were represented in the studies. And overall, mini plates performed slightly better than mini implants, but not by a crazy amount. And average treatment times were comparable, and the severity were a little more severe in those mini plate articles were treated with mini plates in comparison to the mini implants. But overall, TADs are comparable to orthognathic surgery, and so going into the future, we're going to see a lot less orthognathic surgery and a lot more treatment just because of the less invasive nature of TADs comparable to that as well. Acknowledgements, so Roseman, and here are the references. Thank you so much.